तर ह्या सेशनसाठी डॉक्टर राकेश रंजन सर आहेत. तर सरांचं आपण थोडंसं इंट्रोडक्शन घेऊया. 2 दशकांपेक्षा अधिक अनुभव असलेले ज्येष्ठ न्यूरोसर्जन, MBBS त्यांनी AFMC, नंतर MS आणि MCH चंदीगड येथे पूर्ण केले. दिल्लीतील अग्रगण्य कॉर्पोरेट हॉस्पिटलमध्ये काम केले असून भारतात इनऑपरेटिव्ह MRI न्यूरो इनोव्हेशनच्या प्रारंभीचा अनुभव घेणाऱ्या शल्यचिकित्सकांपैकी एक आहेत. त्यांनी UCSF USA येथून पेडॅट्रिक न्यूरोसर्जरीमध्ये क्लिनिकल फेलोशिप केली आहे. डॉक्टर रंजन सरांनी 25हून अधिक संशोधने प्रकाशन व 100हून अधिक राष्ट्रीय व आंतरराष्ट्रीय सादरीकरण केली आहेत. त्यांचे विशेष कार्यक्षेत्रामध्ये बाल न्यूरोसर्जरी, शस्त्रक्रिया, मिनिमल इनोव्हेटिव्ह न्यूरोसर्जरी यांचा समावेश आहे. अशा ख्यातनाम व्यक्तिमत्वाला आपण या व्यासपीठावर आमंत्रित करूया. वेलकम यू सर.
I am actually, it is a big pleasure as well as I am honored to attend, and thank you to NIMA and your Ayurvedic whole fraternity, because gathering such a big audience on a Sunday, this is actually, we don't find a lot of times in our societies happening. So a big thank you, and I actually heard one of the sessions prior to the lunch. I do realize that Ayurveda has got a big role in the healing of the general population. So in chronic disorders and as well as some of the disorders where we don't know what the treatments are, all the ways of medicines are of importance, and we don't stand at a pedestal where we should look at the other front. In fact, it is an opportunity to talk and to get in a common point of view. So has already talked a lot about Parkinson's disease and deep brain stimulation as such. So that is the reason why I thought maybe to expand the whole talk to what exactly we do as a neurosurgeon, or what exactly the neurosurgery is going to be. So when we talk at the perspective of neurosurgery, nowadays it is not neurosurgery anymore, it is a comprehensive neuroscience. And that is where a role of multidisciplinary approach makes a huge difference to the patient outcome. So when this deep brain stimulation surgery is, we hear, or similar kind of therapies, we know that it is not just one specialty which plays a role. So there is a physician who works as an anchor because the patient will reach here, but allied specialties like physiotherapy, speech therapy, and so many other specialties come and play a huge role in the outcome of patients, wherein the surgeries are certainly going to aid into the overall achievement of outcomes of these people. So I similarly, in other fields of neurosurgery or neurosciences as such, we see huge opportunities happening because of collaborations. And this collaboration is just not limited to surgery. It happens right from diagnosis to treatment and to rehab. So I will just cross the multiple paradigms, and I would like to highlight why a center of repute or a center which caters to the holistic approach to these fields make a better outcome as compared to just peddling around doing one procedure and not following it up. So neurosciences is not an old specialty. You see this, there are skulls which have been found from Inca civilizations, a skull which has got this which has healed. So you can see a hole in the skull which has healed. That means a person has survived the insult. So, and this only suggests that 2000 years back ago, probably somebody was doing a magic science, and then still somebody was practicing some kind of neurosurgery. Neurosurgery per se is not an old specialty like medicine or as you are all here, Ayurveda, which starts right from Sushrut. So And neuromodulation, which is a newer form of therapy, it has a huge role to come into play, as I will take you towards the end of the slide. So you see various pictures here. These are neuromodulation techniques which are going to be available, where they're putting catheters through the venous sinuses into the brain to improve the memory. So when we talk about the neurosurgery, this is from 1869. Father of neurosurgery was Harvey Cushing, that is what we call him. He was born in 1869, so not old, hardly. And then subsequently, with a lot of neurosurgeons which came in Western Hemisphere, however, the recent most who is called the father of modern neurosurgery, he is Yasar Gil. He was actually born in Turkey. He fled World War II, reached Switzerland, and he set up a place which was a center for stereotaxy. So this was a center where actually stereotaxy got it settled, from where the gamma knife developed, and from where we had the evolution of stereoencephalous sciences. And similarly, we had also the whole evolution of DBS, what we'll call. So where has the neurosurgery progressed now? When we talk about all the surgeries which are available. So now, the progression is towards minimal invasive, so damage list. Initially, there used to be bigger exposures, longer incisions, cutting of the skull bones which were bigger in size. So obviously delayed healing, outcomes was poor. So I remember one of my statements from one of the senior neurosurgeons from the country. He was trained in 1960s and practiced in 70s, 80s. So he was trying to collect the data during his 80s, right, for posterior fossa tumor resections. So he told that he wanted to present it one of the conferences in the Western Hemisphere. He collected 160 patients. You know, the mortality rate was 90%, right? So you see how much progress has been made. And the progress is that now a person who walks in with a neurosurgical illness or such, there is almost 95% certainty that he will go back. And there is a huge possibility that people who will come in a sick state, there is a treatment to be offered. And if you come at the right place at the right time, miracles can happen. This we will see how the things have changed. So similarly, even though the technology will keep on moving, we have to be patient-centric. So whatever we have in the end of the game, that doesn't mean that it will work for every one of us sitting here. So every patient will respond to a different treatment in a different way, will live in a different circumstances in a different manner. If I do a very high-end procedure to somebody who doesn't have ways or means to live in the society, the outcomes will not be the same. So we need to understand what is patient centricity. We need to understand what are the long-term outcomes. A young patient and the old patient, the treatment we offer may not be the same. And similarly, what is new happening, that is the role we are coming to DBS and other neuro-restorative therapy. So how does the advancement occur in the field of neurosurgery? It is obviously the better anatomy and neurophysiology understanding. Cutting-edge technology is certainly a must, because that is what changes the perspective, and surgical techniques have become better. So just to fulfill what kind of neurosurgery we deal or heal to, one of the most common of neurosurgical problems which you see, or neurological problems, is stroke. Stroke, both ischemic and hemorrhagic, huge burden to the society, mortality, disabilities. So if you look around in all your practice, I know there are centers in Nipani and centers in Puntamba, where every other patient who goes to a stroke, next month, see, I think this is one of the success of Ayurveda, right? Somebody, right, the day he gets a stroke, next month the patient will come. Whether he takes antihypertensive or not, he wants to go there, right? So that is the way it is, how the society feels. So there is a huge challenge and a huge opportunity there, how you can make a difference. Similarly, pediatric cases where you have diagnosis missed, symptoms neglected, and subsequently the outcomes which are poor. So how can these be different? Geriatric, again, in a big manner, as we have just heard about Parkinson's and others. Then a spine will cover subsequently. Neuro-oncology, again, because the outcomes are changing. Functional and restorative, where the DBS comes. And trauma, we all know there's nothing much to. So when we talk about DBS surgery, how did it evolve? So DBS is something which evolved from late 19th century. So earlier what happened, few of the anatomists wanted to stimulate the brain through putting electrodes in dogs and others. So they were actually trying to localize the function of the brain. So by stimulating, and I don't know whether you have heard about Broca and all, so they actually did experiments to touch the different areas of the brain and find out what happens to that. And so that is how they came to know there are centers of the brain which are responsible for certain action. Next came stereotactic frames. That is what I talked about, the Sargil and the center. Then came listening. You will be surprised to know in 1950s, Ravi Verma practiced in Bangalore. He had one of the earliest series for listening in the brain for Parkinson's. Gone into disrepute because of many reasons. We'll come to that. Same came high frequency stimulation of VIM nucleus of the thalamus for tremors. This was tried, but at the same time, levodopa came in. So the surgery got not into disrepute, it fell into the second line therapy. And that is when actually however, the next few further advancement came was when Alan Benbid did a DBS for tremors. So it was actually for the essential tremors that the DBS surgery came back again, and subsequently, as the therapies became well understood, levodopa, we knew that some people will have a holiday or a honeymoon period, and then subsequently they will have again symptoms which doesn't get better again. So there the DBS role came. So subsequently, the FDA approval came as late as 2002. So it's not new. How does it work? So basically, you have got three parts. Now, we have already heard about Parkinson's disease. There is for dystonia, essential tremors, writer cramps, now psychiatric disorders. So obsessive compulsive disorders, depression, and so many others where it has been tried. So basically, what you look at is one is electrode, second is a connecting wire, and third is a pulse generator. Pulse generator which is attached with a battery just like a pacemaker, as it was told. As you stimulate, you will see different waveforms coming from the different stimulation. That is how a neurophysician will come to know whether the right part of the brain is stimulated and whether you have the right current to get the right outcomes. So how is it performed? It can be performed under local anesthesia. It can be performed under general anesthesia. In the center in UCSF, I have seen surgery being done in intraoperative MRI gantry where the patient used to be awake. So right during the surgery, you can actually make out whether you have hit the right target both anatomically as well as functionally. So you see this image. Basically, they are trying to look at that what are the different areas of the brain which can be stimulated by various techniques. So you just heard that a subthalamic nucleus or GPI, that is a globus pallidus interna, stimulation is most common in Parkinson's. But it is not so in other disorders, like nucleus accumbens. Then you have other stimulus where is like areas with the cingulate gyrus, which works much better in cases of psychiatric disorders. So when do you think of doing a DBS in Parkinson's disease? Confirm PD for more than 5 years. These are basic guidelines which needs to, so as it was told by Bhushan, people who get better with levodopa, they will get better with a DBS. That is one of the general paradigm. So what are the targets? Just I told, GPI, that is a globus pallidus interna, subthalamic nucleus, VIM nucleus of the thalamus. So one of the disadvantages of a GPI is suicidal tendencies. So we'll go to that. Just I will cross over what are the other indications. So you will keep on seeing that as it was told, that in Parkinson's disease, usually one side is prominent. So the opposite side of the brain will control that side. So unilateral DBS will work. Whereas when we compare to dystonia and all, most of the times bilateral DBS is one of those indications. And it is usually common in cerebral palsy. Some of the times you have myoclonus dystonia and other features. I will just jump on so that we can move to the next this. DBS for essential tremor, thalamus is the target. OCD, that is an obsessive compulsive disorder, nucleus accumbens, and anterior limb of internal capsule. You see this? Here, SCC is the area where the target is. Sometimes it is in the cingulate gyrus. So what is the success rate? As it was shown by the Bhushan, I was not going to this. Almost 75% of the patients will have symptoms which get better with surgery. 50% will have almost a stoppage or reduction of medicines. And tremors reduced almost in the similar fashion as the levodopa will work. However, there are side effects. That is why it was told none of the surgical interventions will be free of side effects. So you can have suicidal thoughts or other psychiatric target-related side effects. Then you can have procedure, as you might be aware, implant-related, implant breakage, migration, malplacement, other things, and battery-related. Nowadays, there are companies which have come with auto, something like battery which can be charged by itself. Functional neurosurgery has advanced in the other forms like targeting, which we just talked. Then is MR guided focused ultrasound. So what you do is you make a planning based on the MRI where you plan to. Then you have similar to what you put in a needle and an electrode inside the brain, you do a focused ultrasound and you strike in there where you want to stimulate. And that is where you do the listening. Similarly, you have other indications in functional. So we just had an outlook what exactly we do in functional disorders or movement disorders and psychiatric disorders. Similarly, there are a lot of other indications which are functional diseases where a neurosurgery will have a big role to play. And they are much common. One of them is trigeminal neuralgia, hemifacial spasm, right? Tinnitus. Similarly, in spinal cord injury patients, people who have got failed back syndrome, spinal cord stimulation has got a huge role. One of the limitation in Indian scenario is the cost. However, it works. Intrathecal baculoform, patients who have got cerebral palsy, spasticity following trauma, they work quite good with intrathecal baculopump, and somewhere where people don't have the finances to, there are dorsal rhizotomy which works. So I will just tell you how sometimes functional aspect of neurosurgical or neurological illness can be bad. A patient who came 56-year-old, severe facial pain, has got almost 4 to 5 teeth extracted because of severe pain, on 3 medication not getting better, has got minimal relief, almost he has got suicidal depressed thoughts. One decides to undergo surgery. He had a nerve compression because of an artery, superior cerebral artery. So what you do, you basically just separate the nerve from the vessel, and you will see that how, we'll go fast. This is almost like a minimal invasive surgery where the opening is not bigger than a burr hole, right? But the moment you will see that so the moment you see that you open the dura, you separate the cerebellum, you reach the trigeminal nerve. And the moment you reach the trigeminal nerve, there is a vessel which is almost impinging on the nerve. And you know that the moment you separate the nerve from the vessel, just by putting in a Teflon sponge, you will see how the nerve is getting near the vessel. There is a white color thing and there is a red color thing. You see that there are 2 vessels which are on the 2 sides of this nerve. So the moment you separate and put in a Teflon sponge, the pain is gone. So these functional issues, you will see a miracle happening almost in following surgery. So coming to the you can see the Teflon graft here being placed, right? And it is being pulled from the artery separated from the nerve. So that is how. Now we'll come to stroke care I was talking about. Why does a stroke center, which is ready right from early stroke team, where you can reach, get a CT scan or MRI in 10 minutes time, get an intervention done in 25 minutes time, and if the patient is well within window period, you can get him to a cath lab and do an intra-arterial thrombolysis or a stent placement. And if there is a problem, there is a neurosurgery backup, you can make a huge difference in the early outcome. You know, one of the earliest stroke thrombolytic therapy came in 1996. And this was with a Harvard medicine professor. He was taking rounds. And during the rounds, he started feeling that his upper limb and the lower limb is getting numb. And he was one of the person who knew that in cardiac thrombolysis was pretty common. So he told his residents to give him intravenous thrombolysis. And within 40 minutes of thrombolysis became better. Now the world has moved so much. So there are enough guidelines and enough support available. Then in Western countries, there are helicopters on call. There are ambulance on call, which has got a cath lab inside. So if you have got the right time, if you catch them right, a person's recovery can be reduced to hours which will not have disabilities which a person suffers from lifelong. Similarly, you have a hemorrhagic stroke. Patients who have got SAH, and usually they will have even today we had a patient, you have a patient, sudden severe headache, you think, try to treat other way. This lady came to us, referred from another hospital, angiography was done, and that showed a posterior communicating artery aneurysm. Now, the moment you see that, one of the options is that you coil, you clip, or you put flow diverter. Now, what will you opt is the best way to offer us option of surgery is to have a team-based approach. None of the patients will respond in a similar manner as when you try to achieve the treatment base. So this patient had a wide neck aneurysm, and as you see that, the moment we go, we separate the vessel, so there's a wide neck, and we're trying to put in clip there. You separate the neck, and then you go in there, and subsequently you find the right kind of clip to get in, and the moment you reach there, you can almost separate the vessel from the aneurysm completely. Then you not only do that, you cut the aneurysm sac, make sure that the vessel is well preserved, and you can have a good long-term outcome. I will jump, right? So similarly, you can have, we had this patient who came with one episode of giddiness, and subsequently on angiography was found to have a MC aneurysm. Now this patient did not, was almost asymptomatic, and there was an aneurysm which was picked up like incidental. What to do? There was a risk of rupture because the aneurysm was more than 5 millimeter. So he wanted long-term therapy, and outcome, he will not tolerate any hemiparesis. So what was the best option here? So, we decided to have awake surgery for the MC aneurysm. This was the first in the country, which we did almost 3 years back. So during the awake part, we did this surgery, and we clipped this aneurysm awake, making sure that the person doesn't suffer during the surgery, doesn't suffer from any hemiparesis. You will see this, that during the surgery, while the surgery is on, we check the patient's movements, right? So you are checking that the person is moving the limbs. You are checking that the patient is talking, and then you can check that the patient's hand and limbs are saved while you ensure that the patient's, this is clipped in a proper fashion. Being awake, the other advantage is that you can almost achieve the repositioning of the clips. Similarly, there was a lady who came recently, had a AVM with a aneurysm, big sitting. What will you do? 51-year-old lady had 2 problems at a time. A flow diverter is the only answer. Just see this aneurysm was such a big aneurysm that once we decided to operate, there were not one clip will work. There were 3 clips which had to be applied. So I will just show you how the aneurysm looked in when we were. So can you see at the top of this vessel here, right? There's a big aneurysm which is setting. Just clipping one clip will not work. And subsequently, when you put one clip, we decided that we will isolate the MCA branch completely. We put a temporary clip there, and then we put in a clip there. Then we separate the aneurysm neck sac from the vessel completely, from the brain. And we know that this aneurysm cannot be clipped just like that. So what you do, we put in multiple clips, this aneurysm ruptures, right? And then you will see towards the end of the procedure that by putting in multiple clips, we make sure that the whole vessel is preserved and the aneurysm is completely separated. And in the same setting, we could excise the AVM as well. So a good teamwork will work in the best manner when we are talking about these patients. I will just jump on because I think this is another child who came at 1.5 years of age, had an MC aneurysm. Now, what is the long-term therapy? One of the options was putting in a flow diverter. That is what people have done so many times. But flow diverters, it will not work in a minute. So, let's go. So how will it work? So we decided to operate on this child. The child was operated at 1.5 years. This was one of the earliest age at which aneurysm was clipped in the country. And this child is now doing fine for almost 4 years later. So a long-term outcome with all that works. Similarly, next we come to epilepsy surgery. We know, again, similarly as we talked about DBS, epilepsy surgery is another thing where it is a team-based approach. So you have a person with epilepsy coming. Is every person feasible for epilepsy surgery or not? Right? So there, neurologist will have to work in, and then when the workup is done, there are a lot of times nowadays you will find that things where we think that epilepsy is just a medical disorder. Actually, it might be that there may be some kind of focal cortical dysplasia which might be sitting there, right? So I will just go in quickly now because I think we have crossed time. So this child was worked up, right? So he had a focal dysplasia. Now, how does the center work in a better manner? You see that there is an intraoperative neuromapping where we can look at the electrodes and then see, and then we separate the whole area of the brain which looks normal from outside. However, on the video intraoperative, this is the cochlear mapping, which you can see these electrodes here, right? So it actually gives you real-time feedback where there is a seizure focus is there or not. So based on guidance from the mapping, you can make sure that you have resected all the areas. So even though you have resected the brain, you later on in the last lower image, you check that we're stimulating the brain and checking whether there is any seizure this out there. So similarly, there are children and adults who will come with repeated strokes or ischemic inserts. These are the Moya disease. We are one of the few centers which do STMC bypass surgery in the brain. So look at this child who had a Moya disease, underwent a STMC bypass, and this bypass was done by harvesting a superficial temporal artery to the middle cerebral artery. So can you see the vessel? Superficial temporal artery has been moved there, and once it is done, there is an adjunct supply which is achieved to the brain. Just coming to other things, brain neuro-oncology, brain tumors are one of the things where we all know that surgery is the answer, but how does a surgery differs from having a multidisciplinary approach? Intraoperative navigation, intraoperative EEG monitoring can save a lot of these patients from having potential deficits. That is where you will have a different outcomes at different centers. So even though they are challenging tumors, microsurgical excision is a routine thing. Having a better technology will work better. This child we operated, one almost 13 months old child, almost a hemispheric tumor, tumor was excised based on navigation and modern therapies. One of the big adjuncts is the availability of CUSA and other facilities. So another patient of medulloblastoma, operated almost 4 years back, doing fine. Scan doesn't show in this. Another medulloblastoma, which is lateral. So what you will understand that neuro-oncology has made a rapid progress, not only in terms of surgery, again the team approach works. So the diagnosis itself is now integrated. So what used to be a histopathological diagnosis is now a molecular diagnosis. I will not go into detail, probably we can talk sometime later, that how does it change later on. In terms of recurrent and repetitive, right, seizures, they are interactable seizures or tumors which come back again, where there are other modes of therapy available. One of them is laser interstitial therapy, where you, similar to DBS, you put in an electrode, you burn that area. Similar gamma knife therapy, I think quite a number of us would have been aware. Cyber knife, proton beam, all these have been started by neurosurgeons, surprisingly. These are paradigms of not neurosurgery now, a lot of people think, right? One of the centers is actually Elder from Stanford. He has started cyber knife. Subsequently, it has been found to be used by other people more. So where will we go now? All of these you saw, there were actually robots which were doing this, putting in implants. So we'll have something like this. You will see something coming in years to come, where you will have almost augmented kind of thing, putting in, doing the surgery for you. It is just an illustration what a company is already planning to do, right? Where you have everything just based on what you have planned pre-operative, based on whatever trajectory you have. So all these are not a distant possibility is happening. How much is happening? It is something will come now. It is restorative neurosurgery. So we are kept on talking about What will happen if the paralysis is there? What will happen if we can't talk? We keep on seeing patients of motor neuron disease where patients' relatives keep on harping on. Now you know that nothing can be done. They can't swallow, they can't talk, they can't walk. Now restorative therapy, you must have heard about Neuralink, a company started by Elon Musk. They are already recruiting patients on that. Prime, this is a Neuralink-based study where they're putting robotically implanted brain-computer interface. So you have this brain chip, which will, this is the middle, this you can see a robo, which puts in an implant, and then the chip will take out the signals from the brain and will help you walk, read, and play games. This is an article which came as early as 2023, where a person who was paralyzed for 20 years, in Switzerland, there were 2 patients who have already undergone this therapy. So you have a brain chip set in brain on both the lobes, gives the signal to the spinal cord, and the patient walks after 20 years. Thank you. This is the child which I operated at the age of 1 year, a MCA giant aneurysm. The parents were happy to share this video. Thank you.